Okay, welcome everyone. This is the session 10 of the Foundations in Critical Care webinar series. We're very excited today to be talking about oncological emergencies. Let's go ahead and get started, and I'll share my screen here. Okay, yeah, so welcome to session 10. We're very excited to have some wonderful panelists from the United States and from Rwanda. Today we have Danielle Davakis, who is an registered nurse, but also a nurse practitioner who has done additional training in critical care medicine, and she is at Stanford University. We have Dr. Toby Kingsley, who works in Kigali, Rwanda, who's an anesthesiologist as well as an intensivist there. Dr. Nicole Arkin, also anesthesiologist and intensivist working at Stanford University. Dr. Gaston is an anesthesiologist and pain medicine physician who also works in Kigali, Rwanda, and does work in the ICUs there as well. Dr. Fred Meem is a professor at Stanford University who is trained in both anesthesiology as well as critical care medicine, as is Dr. Amy, who is also at Stanford University, who does anesthesiology, critical care, and cardiac cases as well. Dr. Jackson is in Kigali, Rwanda as well. He is an anesthesiologist, works in the intensive care units in Kigali, Rwanda, and also helps with the residency program there in Rwanda as well. So very good set of panelists today from across the globe, all of us working in critical care and most of us having seen a lot of cancer patients and the complications that occur for those patients. We want to remind everybody that this is a place of learning. We want it to be respectful. We have lots of learners from all over the globe with lots of backgrounds, different languages, different cultures. So we want to be respectful. If you disagree with something that someone says in the chat or the Q&A or even one of us panelists, please disagree with respect and be constructive in your feedback. This is a place of learning. We do have the Q&A function at the bottom of the screen. Please send any of your questions that you have through that Q&A box, and feel free to introduce yourself in the chat box. So tell us who you are, where you're from in the chat box. We'd love to get to know all of you more. We want to build community. If your bandwidth permits, you're encouraged to turn on your video to capture your face or the room. This session is being recorded. Your attendance is your consent to be recorded, and the session will be posted on our Learning Resource Center, and we are also live stream on YouTube currently. So we'll share the link for the LRC or the Learning Resource Center in just a minute. Closed captions are available. You can see them at the bottom of your screen. This may be helpful for those for whom English is a second, third, or fourth language. So you can follow along with the closed captions. We have an online school called the Global Anesthesia and Critical Care Learning Resource Center. This school is free and open access. All of our materials, our slides, our notes, our videos, our resources for learning are available for free on the Learning Resource Center. The slides and notes from today's session have already been uploaded to the LRC. So you are very welcome and encouraged to follow along with the slides or review them later or share them with others. If you registered for this session, you will receive CME or CPD credit through Stanford. You have to follow the link in order to claim your CPD or CME. You will receive an email after registration that gives you instructions on how to do that. So make sure that you get your certificate of attendance and your CME by following the instructions in this slide, which will also be shown at the end of the session, and you should have also received it by email if you registered. This is the slide we'll show again at the end, so I'll give you more information about the CME as well as the, oops, sorry, Let me go ahead and share my screen again and get the other slides up. Yeah, this is it. I'm almost there, I promise. Okay, now we are going to get started with our session on oncologic emergencies and critical care. We're going to talk about the management of time-critical complications in cancer or its treatment. We want to be able to recognize that there are many medical complications that occur in cancer patients, and some of these are time critical and or emergent. So we want to be able to recognize those medical complications from different types of cancers. Additionally, complications are common in these patients due to the treatments of the cancer. So we want to also be able to recognize medical complications due to the treatment of cancer. We are going to organize this by understanding the treatment strategies for major oncologic emergencies, including the metabolic, hematologic, structural, and treatment-related complications. And we want to be able to the best of our ability, adapt these strategies to your settings and your level of resources. We recognize that not everyone has the same level of resources or access to some of these things. And so with that, I'm going to turn over to Danielle, who's going to get us started on common complications due to cancer or its treatment.
Thank you. All right, so there are many complications that can occur as a result of oncologic processes. These time-critical medical conditions can occur because of the cancer itself or the treatment of cancer. Common complications due to cancer include TLS, SVC syndrome, DIC, leukostasis, hypercoagulable states that include DVTs or PEs, as well as solid tumor invasion or metastases, sepsis, neutropenia, CRS, and CAR T complications, as well as toxicity to chemotherapy and immunotherapy infectious complications. And there's also more that we're not even listing. This session aims to cover a few of the most common time-critical or emergent oncologic processes seen in these critically ill patients. It is worth noting that we will not cover all cancers or all complications that can occur. All right, we will further explore the oncologic emergencies using this organization table. It includes metabolic, hematologic, structural, and treatment-related conditions that can lead to critical illness and need for time-critical care. This discussion does not include all cancers or all complications, but we will attempt to cover the most severe and life-threatening. All right, starting with, can you go to the next slide? Thank you. All right, starting with metabolic complications, we will briefly discuss the management of various actual electrolyte disorders and tumor lysis syndrome.
Is Dr. Jackson with us already?
I did not see him.
Okay, perfect. So I can help with this slide while we wait for Dr. Jackson to arrive. But most of us are familiar with electrolyte disturbances. These occur not just in cancer patients, but in many of our critical care patients. So this is really just a refresher, not an exhaustive discussion about electrolyte disturbances. But some of the common ones that you see in cancer or cancer treatment include hyperkalemia, and I think you can all remember that the core treatments for hyperkalemia is to either shift the potassium back into the cells, which can be done with insulin and beta agonists, but also to remove the potassium from the body, and that can occur through loop diuretics or dialysis. Hyperphosphatemia is another common electrolyte disturbance in these patients, and its treatment includes phosphate binders for a more chronic hyperphosphatemia. And in the acute hyperphosphatemia, you need to make sure your patient is well hydrated, for which you can use saline. Hypocalcemia as well as hypercalcemia are also common. Hypocalcemia requires calcium repletion. However, in one syndrome that we'll talk about, tumor lysis syndrome or TLS, we want to avoid calcium repletion unless the patient is symptomatic with severe hypocalcemia. And this is due to calcium binding to phosphate, creating these deposits that can lead to acute kidney injury. The clinical signs of hypocalcemia for which you would consider repletion include tetany, carpal pedal spasm, seizures, hypotension, prolonged QT intervals. Calcemia is another problem. And for this, you can give isotonic saline, you can do subcutaneous calcitonin or IV bisphosphonates. And then SIADH, or syndrome of inappropriate antidiuretic hormone, leads to hyponatremia. And for this, we can do either fluid restriction. Sometimes it requires hypertonic saline if it's severe. And then we can also use loop diuretics if needed.
Great. Thank you, Anna.
Thank you, Jackson.
Yeah, I'm Dr. Gaston.
Oh,
Zana
Gaston. Sorry,
introduced
sorry,
me.
Gaston.
Okay.
Sorry, I
Sorry.
didn't see you. I was waiting for Dr. Jackson, and so I covered his slide, but we're super happy to have you, Dr. Gaston. Murakoze-chan.
Thank you. Okay, so among metabolic complications, we continue with the so-called tumor lysis syndrome. And by definition, is massive lysis of tumor cells that release potassium, phosphate, and uric acid into the blood circulation. So, I mean, this happens when a large number of tumor cells are destroyed rapidly. And this destruction of a large number of tumor cells leads to release of those potassium, phosphate, and uric acid. And serum calcium is decreased as calcium binds with the phosphate, and that is released from the least cells. And this happens, of course, as we said, when you have started the chemotherapy, and then and sometimes when the tumor starts increasing. So uric acid and calcium phosphate deposits, they can lead to acute kidney injury and renal failure. And so due to this metabolic derangement, tumor syndrome can lead to severe symptoms including nausea, vomiting, anorexia, so lethargy, hematuria, heart failure, cardiac dysrhythmia, seizures, muscle cramps, or tetany, and all this can happen. So some may have left flank, pelvic pain, and all those things. Next. So how we diagnose this? So this TLS can be diagnosed using laboratory diagnostic that measure potassium, phosphate, and uric acid, but it also has clinical criteria. So we have two wings, laboratory and clinical. So these Cairo Bishop grading systems diagnose the laboratory TLS according to level of uric acid, potassium, phosphorus, calcium, and the timing of these abnormalities. So the lab abnormalities must occur within 3 days before or 7 days after chemotherapy is initiated. And when you look at this clinical TLS, is suggested by elevated serum creatinine and cardiac dysrhythmia, seizures, or sudden death. So, and this is how we can diagnose these two or using these two wings. So, when you read the numbers, and you can see this for laboratory, the uric acid levels has to be more than 8 milligram per deciliter, or 25% increase from baseline. as well as potassium more than 6 milliequivalent per liter, still 25 increase from baseline again. Phosphate level, it can be more than 4.5 milligram per deciliter or 25% increase from baseline in children, or more than 6.5 milligram per deciliter in adults, as well as the calcium on this level. And this clinical TLS, then you mostly, we said about timing, and the patient must meet the criteria for laboratory TLS. So these are clinical manifestations where you have serum creatinine increased and cardiac arrhythmia, as we said. So the next will be
I want to pause here,
study.
Dr. Gaston, if we may, because one, this slide is somewhat complicated, and two, it makes me think of one of our learning objectives, which is how do we adapt some of our goals and guidelines to practice settings that may have resource constraints. So I know, for example, at Stanford, we check labs very, very often, and our lab results come back very, very quickly. But in some places, you can send labs, and maybe you don't get your results for a day or two. Um, so it would be challenging to continuously follow these labs to make the diagnosis of tumor lysis syndrome. Can you make recommendations on how, for example, if you're in a district hospital, how you would be able to use these criteria to make the diagnosis and treat a patient who you suspect would have tumor lysis
Mhm.
syndrome?
Yeah, so let me highlight a little bit. So at least, so when you go for laboratory, you might have like uric acid level you don't measure in your laboratory, or potassium, phosphate, but at least two of these four or five has, I mean, like if you have calcium, you can measure calcium level or uric acid. If you have two, that is enough to diagnose for laboratory TLS diagnosis. And for clinical, that is mainly, you can see that. So
That's
cardiac arrhythmia, some centers don't have like EKG, and some others can't, define the seizures or what, but this is clinical, so you can do that.
yeah.
So I know that some of the areas, they don't have laboratory tools to get this, but at
Mm,
least two in terms of laboratory. So yeah.
yeah.
Mhm.
Also, this is more of a question for all of our panelists, but I would say out of the laboratory data, there's a lot of things that can change your potassium level or your phosphate level or your calcium level. And so that maybe uric acid is the most specific for tumor lysis syndrome. But what do the other panelists think? What do you think, Dr. Nicole, Dr. Amy, Danielle? If you only had a couple labs to choose, which one would you choose?
Uric acid would be the most specific, I think.
I think about things that are going to kill the patient. And so I think potassium level is pretty important. One of the things that was mentioned in the chat um, is checking ECG, which gives you really fast feedback. I think that's a great suggestion because you will be able to see things like hyperkalemia. You can also see evidence of calcemia as well. And so I think ECG will give you really quick information. While it's not terribly specific, if you already have a high index of suspicion, you may recognize that you need to start hyperkalemia treatment because you have peak T waves. So just do it, and you may not really need to wait for the lab result to come back.
I think that's a really great point. So making the diagnosis may not be as important as treating its complications. Thank you.
Mhm.
Great. Dr. Toby, can you help us with how do we determine if our patient is at risk for tumor lysis syndrome?
Yeah, thank you, Anna. I think one of the things is, we need to look at the high risk. You want to see, does this patient have a cancer? Does this patient have, the kind of cancer the patient has? And the clinical presentation of the patient would help. So the important thing is you look at if you look at the Cairo Bishop score, we want to see the onset of the symptoms, all right? And these are clinical correlates that can be used in addition to your laboratory and your other monitorings, especially the EKG. But I think it's important for you to, for instance, a patient who has no cancer, no treatment for chemotherapy has started, and the patient has this laboratory derailment, you obviously tumor lysis syndrome won't come to your mind. So I think the kind of patient you're dealing with will give you an insight into what you're dealing with at that moment. Hello, Anna?
Yes, yes, I'm here.
Yeah, I guess Gaston took part of my slot. I don't know if he's continuing with that other slides or.
No, that's okay. So this slide is for you, but it's really just to highlight that we have some tumors that are very highly associated with tumor lysis syndrome, some tumors that are intermediate risk, and some that are low risk. So the high risk patients are patients with Burkitt lymphoma, mantle cell lymphoma, especially with bulky disease, leukemias, specifically T cell acute lymphoblastic leukemia and chronic lymphocytic leukemia. Multiple myeloma or solid tumors can also cause tumor lysis syndrome, although less commonly. So it's really good to know what type of cancer you have. That way you can determine the risk level for each patient. So
Yeah.
once you know whether it's low risk, intermediate risk, or high risk, then you can determine the types of treatments. Did you want to talk more about this, or do you want me to?
Yeah, most of the things, I hope you're hearing me. Can you hear me?
Yes, sir.
Yeah, most of the things you mentioned them. So like the type of tumor will give you an indication whether it's high risk or intermediate or low risk tumors. And some of these things you've mentioned them. Those tumors with high proliferative rate, all right, and those tumors that are sensitive to chemotherapy or your targeted therapy, all of this will help you to make a diagnosis of your tumor lysis syndrome. And also, in addition to the type of malignancy, the risk of tumor lysis syndrome is also increased according to the extent or severity of the disease, the type of treatment being given, and its cytotoxicity of the treatment that is being given. So patients, prophylaxis, patients with low risk, it's important that when a patient is deemed to be low risk, prophylaxis should be started, including just hydration and monitoring of your TLS labs, like what Gaston mentioned before, your phosphate level, your potassium, uric acid, and the calcium level. Now, if your patient falls into the intermediate risk category, all right, hydration and monitoring will continue, but you want to add the allopurinol, all right, which also helps with the uric acid elevation. But if your patient is high risk, according to the parameters that we've mentioned, all right, you want to continue with hydration, aggressive hydration, monitoring, and you want to start with a prophylactic rasburicase, all right? But note that rasburicase is contraindicated in patients with GCSPD deficiency, patients who have experienced severe hemolysis, all right, methemoglobinemia, or anaphylaxis to your rasburicase with viral treatment, or in patients who have high risk for those reactions. Note that rasburicase is very expensive, and when it's not available, all right, you don't throw your hands in the air. You can use your allopurinol. Thank you.
Dr. Kingsley, is allopurinol and or rasburicase available in your ICU?
Not presently, but in Namibia we did have allopurinol, but not I've not used it here since I came to Kigali, but we had when I was in Namibia. Thank you.
Dr. Gaston, do you think that they have it at King Faisal Hospital?
Yes, we do have it.
Oh, hi, Jackson.
Hey,
Okay, perfect. So why do we use allopurinol and rasburicase in these tumor lysis syndrome patients, Dr. Kingsley?
Yeah, they use if we know the pathophysiology, especially with your uric acid, what's it called, uric acid production, all right? It helps to mop up all those uric acid, and especially the rasburicase. But with the use of allopurinol, all right, it helps from the production of the uric acid from your xanthine broke down. So that is what is used for to kick out, so to say, uric acid that is being used. In fact, some books call it kill uric acid with your allopurinol and or your rasburicase. Thank you.
Yeah, I think it's important to recognize, like, since allopurinol decreases the formation of uric acid, so it decreases it from the xanthine to hypoxanthine. It can decrease the production of uric acid, but it doesn't necessarily decrease the uric acid levels that are already present. But it can help quite a bit, and it's very inexpensive. So allopurinol can translate to about $1 per tablet, or $30 per month, or $365 per year. Rasburicase, however, works a little bit differently in that the uric acid that is already present is then broken down. But the price difference is remarkable. So rasburicase, some studies suggest that a single dose may cost around 1,900 US dollars. So very, very expensive, even though it's effective. It can be cost prohibitive to use in these patients, unfortunately.
There was a question in the chat. Are there any other patient groups where rasburicase would be contraindicated? And I wanted to pose that beyond the poor kidney function folks.
Yeah, so the G6PD patients, it's contraindicated in those. And then every time you do a contraindication, is like someone who's had anaphylaxis, but that's a contraindication to any medication that you're going to give. So that would be another consideration if they've had a negative reaction, etc. I think those reactions, if they're life-threatening, are certainly contraindications, but if someone has a side effect, it may be more important to treat the tumor lysis syndrome and tolerate the side effect. But yeah, those were the main categories.
Thank you. All right. There are several hematologic complications that can occur with cancer or its treatment, including hyperviscosity syndrome, leukostasis, disseminated intravascular coagulation, and hypercoagulable states, as well as immune suppression with neutropenia. This next section will discuss hyperviscosity, leukostasis, and neutropenic fever.
Wonderful. Thank you, Danielle.
All
Dr.
right.
Larkin.
So for hyperviscosity syndrome, the description includes some very long words, like lymphoplasmacytic cells that invade the bone marrow, immunoglobulins in the blood that lead to thickening of the blood, and hematopoietic cells that invade other tissues. And really what this results in is, as the name suggests, just increased viscosity or thickness, sometimes stickiness of the blood, that can cause problems in different organ systems. So there's certain types of malignancies where this is going to be more common. And so think about the ones that have that are clonal disorders like multiple myeloma, Waldenstrom's macroglobulinemia, and then some other autoimmune conditions can also be implicated here. Symptomatic hyperviscosity is a medical emergency, and the treatment of choice here is plasmapheresis, which essentially just removes the clones from the blood, and restores normal viscosity. So how do you know if someone needs that? We really only do plasmapheresis because it's very resource intensive, expensive, and exposes the patient to blood products and things like that, for patients who are symptomatic. And so symptoms can include anemia, profound lymphadenopathy, organomegaly and hepatosplenomegaly, peripheral neuropathy, weight loss, fevers, night sweats, and potentially the most specific would be oronasal bleeding in this circumstance. They can also have neurologic complications of blurred vision, headache, and then severe consequences like stupor and coma. So kind of going a little bit more into kind of what does this emergency uh, triad look like? So clinically, what you may see is a patient presenting with neurosymptoms that could be anything as kind of mild as headaches, but then progressing to dizziness, confusion, seizure, comas. Vision changes, which can be due to a retinopathy, so blurred vision, floaters, dilated or tortuous retinal veins that can be seen on exam. And then perhaps the most specific, maybe abnormal bleeding in the form of nosebleeds, gum bleeding, or bleeding with minor procedures. Laboratory evidence is tricky in this group because some of these tests are not readily available or not available in a time frame that returns quickly. And so sometimes you just need to go with the clinical picture, your clinical suspicion, and then on the peripheral blood smear may give you the quickest turnaround in terms of seeing the rouleau formations, which is when red blood cells are sticky and kind of stack together like coins. And that can be suggestive of high viscosity. Other laboratory tests that you can get include a serum viscosity test and a protein gap. Um, the protein gap can give you a sense for if you just have a high protein load that may be contributing to hyperviscosity. But really, it's going to be a clinical diagnosis in patients who are high risk.
And I imagine if Dr. Arkin, you're at Stanford University and you're saying these lab tests are either unavailable or take too long, that a lot of the smaller hospitals, more rural hospitals, district hospitals, et cetera, are probably not going to have this access to these labs. So I think it's very important to recognize that clinical triad. And if you have a question at all, go ahead and try to do plasmapheresis. Plasmapheresis is also very highly resource intensive, as you mentioned, and not available everywhere. So keeping the patient hydrated may be the best next step. Thank you for that. That's great. What about leukostasis? What's the difference between hyperviscosity and leukostasis, Dr. Amy?
So leukostasis, in order to have leukostasis, you usually have to have hyperleukocytosis, which is just an elevated white blood cell count. We usually say hyperleukocytosis is a white blood cell count over 100,000 microbes per liter. And the interesting thing about this is it's not just the absolute number of the cells, it's also the type of the cell that you have. So you can have certain malignancies like CLL, where the cells are well formed and small, and you're not going to get the symptoms of leukostasis. So usually in order to have this, you have to have the elevated white blood cell count in addition to abnormal white cells, most commonly AML, just because they're large and they're malformed and they're stickier. White blood cells are usually significantly larger than red blood cells, especially in this immature blast form in these malignancies. And they clog these small blood vessels and compromise perfusion to tissues, which is where you get the clinical presentation. So leukostasis in and of itself is a medical emergency. And so again, you have to have this hyperleukocytosis, a really elevated white blood cell count, plus symptoms of decreased tissue perfusion. So you can either be altered, have headaches, lightheadedness, visual disturbances, tinnitus, or you can have chest pain, shortness of breath. Shortness of breath is honestly one of the most common things that people present with, although also multifactorial because they're usually anemic as well. And then less often you can have GI symptoms, true cardiovascular complications, things that they can kind of function like they have a PE, or that they can have sort of elevation in their troponins or cardiac disturbances, and other organs, renal complications can affect as well. Hyperleukocytosis can occur with AML. And other hematologic malignancies, like I talked about, like CLL or ALL, but leukostasis rarely occurs except when you have AML.
Yeah. Dr. Amy, thank you so much. We really appreciate this. I'm going to ask you to speak just a little bit more slowly. We have several non-native English speakers. And I speak as fast as you do, but I have to really tell myself to slow down a little bit. So, and just to recap, because I think sometimes it can be confusing, we talked about hyperviscosity, which is really thickened blood from paraproteins and abnormal cells. But that's different than leukostasis, which is really just elevated white blood cells. So those white blood cells, and specifically to acute myeloid leukemia. Is that correct?
That's correct.
Okay, great. So how do we treat it?
So the most important thing anytime you have leukostasis is to try to get your white blood cell count lower. And so prompt treatment with cytoreductive chemotherapy is going to be your best treatment choice. Other things, including things like leukapheresis, can be offered, but again, this is very resource intensive and honestly not necessarily your treatment of choice because, like I said, the most important thing is really treating the underlying malignancy. If for some reason you're not sure what malignancy they have, you don't have chemotherapeutic options that are available, and you do have leukapheresis, and you're having signs or symptoms of leukostasis, you should initiate it. But again, the most important thing is really treating the underlying malignancy. The other option that is often started while you're trying to figure out which underlying malignancy they have is starting hydroxyurea. Hydroxyurea is an oral medication that inhibits DNA synthesis, which can inhibit the proliferation of white blood cells. And you can give it concurrently with chemotherapy or while you're trying to figure out what exact chemotherapeutic agent you're going to give. It's also a nice temporizing agent if they're not necessarily eligible for chemo right now, or you're trying to transfer them, that you can start them on this medication prior to initiation of other agents.
I'm going to ask thank you so much, Dr. Amy. I'm going to ask all of our panelists and just kind of to discuss a little bit about access to resources. So we talked about plasmapheresis and we talked about leukapheresis. These things are more likely available in centers that have the infrastructure for things like hemodialysis. So I think I'm going to encourage all of our participants and learners to explore the resources in their own setting, but also the nearest hospital or nearest center that would have those things. If you did not have access to plasmapheresis or leukapheresis, I would just say that keeping the patient very well hydrated would be a good next step, in addition to, giving the hydroxyurea. Are there any other ideas from our panelists on temporizing measures or ways to help these patients if you don't have leukapheresis or plasmapheresis? Any other thoughts? Maybe Dr. Gaston, if you were working in a rural district hospital, how would you manage this patient and getting access? Or Dr. Jackson or Dr. Toby? Dr. Fred?
Yeah, I think it would be important to make sure you don't fluid overload the patient. So I think, as Nicole has mentioned, judicious use of diuretics to avoid fluid overload, because that would be an added insult to someone who's already suffering from leukostasis.
Mm, mm. Yeah. So that's kind of hard when we say to give fluids and diuretics at the same time, isn't it? So you have to you have to determine what your clinical exam is and your cardiac function is in those patients to see where you are. But that's definitely a
And I think another important aspect that is being now modernized is the use of ultrasound.
Absolutely.
Ultrasound helps you to assess fluid status of your patient and then guide the decision making when you just hydrate your patient. And this, in our country, like where I used to work in a district hospital, when you have a such patient, maybe a kidney failure patient, you need to be meticulous when you hydrate a patient, maybe using ultrasounds, passive regularize, and then see how the patient is really with all of this.
There you go, Murakoze. And so ultrasound for fluid status or volume status. And you can also look at, you can use ultrasound to look at cardiac function. So to make sure the patient doesn't have, for example, right heart failure or left heart failure. You can also use the ultrasound to look at the lungs, because if we volume overload a patient, we will also see pulmonary edema or pleural effusions. So that ultrasound is very, very helpful in many, many ways. Thank you for pointing that out, Dr. Jackson.
You're
That's
welcome.
great. Thanks. Okay, what's another hematologic complication?
So another hematologic complication is febrile neutropenia, and this mainly happen with the pathophysiology, as many of us can see slides. It's mainly starts with neutrophilic sense, which are sensing bacteria presence, and with that, with the role of neutrophilia in the blood, just combat all this kind of strange or foreign body into the bloodstream. And then all the neutrophilic, when they are functional, they're gonna just try to engulf or just try to combat all this foreign body into the system. With that, we're gonna be having with this cancer patient, we were there will be not enough neutrophilic, or the neutrophils are dysfunction. The body can be easily overwhelmed by infection, either bacterial, viral, or fungal. With that, of course, what we be following up is just having fevers. Fever may be the earliest unknown sign of infection in cancer patients. And in general, neutropenic fever develops in approximately 5 to 10% of solid tumor patients who are on chemotherapy, of course, and are at low risk for medical complications, compared to 20 or 25% of non-leukemic hematologic malignancies patients. And as you can see, when you have acute leukemia patients, 85 to 95 gonna be having fevers. So with all these cancer patients that we have, we need to have think mostly about tumor types, and then be more suspicious of what can happen with these neutropenic fevers. And when you're working now low resource settings like our district hospitals back here in Rwanda, this is an exclusion diagnosis. You need to exclude the other things that can lead to infection. But again, having in mind that sometimes classifying the tumor may be difficult.
Thank you so much, Dr. Jackson. I think at the very beginning you said febrile neutropenia. I think it's important for us to realize that we can talk about neutropenic fever, febrile neutropenia, neutropenic sepsis, and all of these things are very similar or the same. And unlike leukostasis, now we're talking about a very low white blood cell count that makes the patient at risk for infections.
Thank you, Anna. And as I said, it's just kind of a diagnosis of exclusion, and by definition, febrile neutropenia, you have single oral temperature which may equal or more of 38.5 centigrade degrees, or temperature more than 38 for 1 hour with neutropenia. With that, you know that this is a very basic laboratory finding that you can be having in very resource limited settings, and having that, you know that this may be, to a cancer patient, this may be a neutrophilic fever, neutropenic fever. The other thing is most common site of infection may be affected, like the GI, from the bloodstream, skin, lungs, urinary tract infection. And then due to neutropenia, patient may have subtle signs or lack of classic findings of infections. Always we need to consider like mucositis, infection of mucosa, and then mucormycosis or tubularitis. All of this may happen to these cancer patients, and to settings where they have labs and who can go for advanced lab investigation. They may go deep and then do investigate and then see what is the trend with these fevers and neutropenia counts. And an absolute neutrophilic count of less than 1,000, 1,500, or 1,000 cells by microliter will definitely show that you have this is absolute neutrophilic count, which may be leading to neutropenic fever. The other severe neutropenia, when the absolute neutrophilic count is less than 500 cells per microliter, or an absolute neutrophilic count that is expected to decrease to less than 548. With that, you will go ahead and confirm that this is mainly neutropenic fevers. Of course, you're going to be needing some of these treatment modalities and everything that may be guiding you to treat your patients. My colleague will go ahead and tell us what are really the criteria to um, define this is, and then how are we going to stratify the patient who is at risk, and then go ahead and manage.
Yeah, thank you. So really the important thing to consider in looking at your patients is to figure out which of your patients are really a high risk and which patients need more aggressive care. And so this slide is just showing you some of the indicators of high risk. And you can see there's a couple scores there, which I will talk about in the next couple slides. And then also the presence of these various medical problems. And you can see them listed here. I just want to point out that mucositis, oral or gastrointestinal mucositis, is something to really take note of. It's no surprise that this happens with patients getting chemotherapy, because the mucosa of the oral cavity and the whole GI tract is a highly there's a high rate of cellular turnover, and most of our chemotherapy drugs, of course, hit cells where there's rapid turnover, and so the mucosa of these patients sometimes can be just horribly damaged and inflamed. I'm point this out only because if you have to intubate a patient who has very bad mucositis, you have potentially a very difficult airway to manage, and you need to be very careful about how you do that. It's also very painful for the patient as well, among other things. Also, we want to pay attention to patients getting certain types of chemotherapy. We know the alemtuzumab and CAR T therapy in particular, we'll say more about the latter on subsequent slides, are predisposed patients to serious complications, and also whether they have progressive cancer, which generally is true because they're getting more chemotherapy, of course, and are neutropenic because the cancer is progressing. And then also if there are organs, liver and kidney involved. Now, this slide's showing the two scoring systems that can be used as a tool. The CISNE score, which is the abbreviation for Clinical Index of Stable Febrile Neutropenia. This is really for patients who are generally assessed as outpatients, and trying to give you a tool to use to decide whether you really should put them in the hospital. I hope you understand that the best place for a neutropenic patient is not in the hospital. Because who's in the hospital? All the really sick patients and all the patients with serious bad infections. And who's taking care of them? Well, nurses and doctors who are taking care of them and this patient with neutropenia. So, you know, we're in a beehive of bad stuff going on in the hospital, and we have to be very careful of how we manage and care for neutropenic patients to protect them from getting those bad infections. So if you don't need to be in the hospital and you're neutropenic, you absolutely do not want to be there. And so this score can help give you some, confidence that you're telling a neutropenic patient with a fever to perhaps stay home, and we'll watch you carefully from home. And in this score, you can see the low score is a low number. The opposite is true on the bottom right. The MASCC score. I don't know where medicine would be if we didn't have abbreviations, but this stands for Multinational Association for Supportive Care in Cancer, in case you're wondering. And this is more for adult patients with either solid tumors or hematologic malignancies, and may be in the hospital already. And this may be helpful to decide how you're going to triage them and whether you're going to put them in the ICU or not, or in a more heavily monitored setting. And I think most of the things listed here are pretty straightforward.
Thank you, Fred. I love your points about abbreviations in medicine, because I'm always like, what does this abbreviation stand for? There's too many acronyms in our language. But I think these scoring systems, I also love your point about if the patient is otherwise stable, to really keep them out of the hospital might be the better thing. But we all know and recognize sick patients, and those are the patients that probably need to be in hospital. But those scoring systems can help us decide. Thank you for those good points.
Yeah, and none of those tools replace your clinical judgment.
That's right.
As you get more experience, you can look at a patient and
they're sick.
You have this gut feeling that this patient's really unstable, and you know what to do, and you don't need a tool to make the right decision.
That's right.
But once you've decided the patient is at risk, though, and we're worried about not just a neutropenic fever, but whether the patient has sepsis or a sepsis syndrome kind of phenomena going on, then we're highly worried about aggressively treating this infection properly and working the patient up. And I think you can see if you can zoom back a little bit and just see on the right-hand side, we have minutes of time. These are not hours, these are minutes. And so the emphasis of this slide is to be aggressive and sense the urgency of completing your evaluation and workup of the patient, and deciding whether they actually are more ill than not, and more at risk. And right up in the early part, if you can zoom in on this, the left-hand side there, that box. Yeah. Yep. Yeah, it is to get early IV access or central venous access if you're able to. This saline is indicated there. I think a lot of people nowadays might argue to use a balanced salt solution like lactated ringers or Normasol or Plasmolite.
I
something of
agree.
that sort.
I completely agree with that point. I think this algorithm probably maybe was written by some oncologists, whereas those of us who manage sepsis and septic shock know that too much saline can cause a hyperchloremic acidosis. And so I think a lot of us would also agree with you to use a balanced salt solution. The one most commonly available, as you know, Dr. Meme, is Ringer's lactate or lactated Ringers.
Yes, and also, by the way, if you're reaching for saline because you're worried about the potassium levels, if you're not careful, you can create an acidosis and have potassium levels go higher, even though the saline has no potassium in it. So saline is not considered as a nice resuscitation fluid as we used to think. The blood
Although if
work
it's
here
the
is
only one available, you should still use it.
it's still
Um,
better than nothing. Yes.
better than nothing.
Um, And in the blood work, you can see the usual kind of blood work that you'd like to get if you have the ability to get these. But most important is to get the blood cultures. And I think if we had an infectious disease person on the line here, he'd be jumping all over this to get the blood cultures before you start antibiotics. And just so because your best hope of curing an infection, even though your antibiotic choice may be just empiric at first, is to actually identify the organism to know exactly what you're treating. And your best chance of getting that is to get it before the antibiotics go in. But you don't want to delay getting the antibiotics in either. So again, you can see 15 minutes, 30 minutes going by, and we're separating out the patients who have altered mental status, hypoperfusion, hypoxia. Those are patients that need to go to a high acuity setting, perhaps in an ICU, and versus those that don't. Now, if we can move over to the other box, in the patients who might not be in a life-threatening state, but still may need some supportive care with supplemental oxygen and just empiric antibiotics because they're sick enough to want to get something going early. Again, the saline is listed there again. I'd probably use Ringer's lactate or normal salt. And you can also see about how quickly they respond. Now, in general, most neutropenic patients are not going to respond quickly. You may get lucky in some patients and have them recover quickly and then continue with oral antibiotic therapy as an outpatient. But that's generally not what I see anyway. So don't expect that. All this is done in 60 minutes, hopefully, from the point of identifying a patient, which is like, I think just the emphasis is on the clock is ticking, and we know that patients who have sepsis have a better chance of surviving if the physicians sense the urgency and get this workup done.
It's not dissimilar from any patient with sepsis or septic shock, really. It's just that the neutropenic patient is at higher risk of having multiple or different types of infections. Would you say that's fair?
Yes, exactly. And 60 minutes, of course, is what is that? That's the golden hour in a trauma patient. There's a golden hour for anybody who gets seriously ill. What are you going to do in that hour?
Yeah.
This slide just to indicate that because these patients are getting chemotherapy and are neutropenic, they have advanced cancer, and so you may have additional problems. Next slide. Of the tumor burden itself, the actual, if they have a solid tumor, they may have spread into various organs that's compromising organ function, or as we'll talk about later, they might have compression of major blood vessels causing SVC syndrome.
Great. Thank you
Next
so
slide.
much, Dr. Fred.
We are now going to discuss the structural complications as Dr. Meme went ahead and discussed. So tumor or metastatic invasion in the SVC syndrome.
Okay,
So,
let's get our audience involved
yeah.
here, Danielle.
Yeah, so that was a lot of talking. Go ahead and drop in the chat common sites for solid tumors to spread or metastasize to.
So we are going to give all of the participants, I'll give you 30 seconds. So in the chat box, type in some of your ideas about where does cancer spread, what types of tumors spread, and where do they go. So I'm going to do 30 seconds from now. So hopefully you're all answering in the chat box.
I don't see very many. There we go. They're coming in.
Yeah, it's
Hello, guys.
Okay, go ahead and help us out, Danielle.
I see a lot of great accurate answers. So some big points are bones, liver, lungs, brain, and lymph nodes. So I'll kind of go through each of those. For bones, the metastases are particularly common, originating from breast, prostate, lung, according to NIH. The spine is a very frequent site, but other bones like your hips, your femurs, your upper arm bones, your ribs, and skull can also be affected. For the liver, it's a frequent site for metastases, specifically pancreatic and colorectal cancers. Lungs can arise from various primary cancers, including the lung cancer itself. As far as our brain can occur particularly among lung, breast, and melanoma, according to the Cleveland Clinic. Lymph nodes are a very common site, as it's a conduit or a pathway for cancer to travel throughout the body. There's also the pleura and the peritoneum. These cancer cells can spread to the lining of both of those organs.
Yeah, this
Good
is
job, guys.
by no means an exhaustive list, but some of the more common places for cancer metastases to occur. I think one of the things that we didn't put on the list that is a common cancer, especially in places without good screening, is cervical cancer, and that is most likely to metastasize to local pelvic involvement or pelvic organs.
Thank you.
Okay, thank you.
Dr.
I think
Gaston is
now
next.
yes. Do you hear me?
Yes, of course. Thank you.
Oh, okay, thank you. So this is now a schematic way to describe that. And so the question is, how does the cancer spread? It's just through the blood vessels and lymphatic system. And here on the picture, there's like the liver and kidney. You can see in the blood and brain, like everywhere. So this is so-called organ tropism. So some say organ tropism, organotropism. So it's really important to know the different types of cancer have different tendencies to spread to specific organs, which is called organotropism. So as we say, the prostate cancer spread to the bones, while lung cancer can spread to the brain, bones, liver, and the other lung. While breast cancer commonly spread to bones, brain, liver, and lungs. And we have colorectal cancer that often spread to the liver, lungs, and peritoneum lining of the abdominal cavity and cause the GI obstruction, liver failure. We get the symptoms, vomiting, hematemesis, abdominal pain, obstipation, jaundice, and others. When you have lung cancer, may spread to adrenal glands and bones, brain, liver, and the other lung, as we said. So melanoma can spread to bones, brain, liver, lungs, and skin. And as we said, prostate can spread to bones and adrenal glands, liver, and lungs. So, but why all of this? So, is there any clinical significance of this? So, the important thing is to understand this organotropism is just to predict the metastatic site once you have a cancer, and then develop targeted therapies and also improve patient outcomes. But I will give a little example here. When we get these patients just to predict all of this? Sometimes you get these present patients in our ICU for complications and from home, like they have been waiting without knowing what is going on. And once they get like respiratory issues, they get here. That's where we diagnose the cancer together with metastasis. Like too late to do something. I know it's different from maybe North America and other developed settings, but this is normally what we should be having to predict all the metastasis. And then when we identify this, we can anticipate where the cancer is likely to spread, which allow us for more targeted monitoring and treatment. So, maybe some people we share what happens in their countries or area, but still there's an issue of early diagnosis of cancer and then which allow us time to think of metastasis and plan accordingly.
Dr. Gaston, that's exactly the point I was hoping that you would make, and I agree with you. I don't think it's necessarily exclusive to resource constrained settings like district hospitals, even in the United States and even in our rural hospitals, but also even at Stanford. You may have a patient who comes in with cancer in their lung, but it's not lung
Mhm.
cancer. It actually is breast cancer. And so sometimes the patients wait too long, and the initial diagnosis is actually of the metastasis. And so when you have a tumor, you need to understand where the primary tumor is, because that really helps us determine how to treat it and
Yeah.
if it's treatable. Once you have widely
Mhm.
metastatic disease, the treatment efficacy really goes down. So you want to catch cancer early. So thank you for that. That's exactly what I was hoping you would discuss.
Yeah, yeah. So, okay, so this slide now is just showing us three-time critical emergencies that can occur with cancer tumors. So you can see this malignant epidural spinal cord compression with this mnemonic, or we have been saying these abbreviations. So this normally there's a pressure on the spinal cord from a tumor causing back pain, weakness, paresthesia, incontinence, or other neurological deficit. So if it's not treated, we just create permanent disability from this. So it's really important to recognize this first as emergency, because once we have a patient with back pain, sometimes in the pain clinic, for example, you get a patient like this, and sometimes the compression is huge and it's really big, and then some people think of normal things like spondylosis or those things. There's no limitation to think about malignancy too, or any other uh, spread of the cancer to the spinal cord. And then the other thing is cardiac tamponade. When you have malignant pericardial effusion and cardiac tamponade, where you have accumulation of fluid in the pericardial sac, and this can compress the heart, impair its function, especially lung, esophageal, and breast cancers. So this can just lead to obstructive shock. So if possible, fluid must be drained immediately to relieve the obstructive shock physiology. Signs and symptoms include chest pain, dyspnea, hypotension, peripheral edema, and fatigue. Again, talking about this, we need a good emergency setup and people recognizing what may happen, because the more you delay in this situation, the worst outcome you can get from this.
You also need Dr.
So
Jackson and his ultrasound probe to come look at the
yeah,
heart.
yeah, exactly. So some of the settings don't even have ultrasounds in rural area and people to use it. Like there's no fast echo. Like, there's the patient is diagnosed based on clinical presentations. So
Yeah.
if there's advocacy to do, it is. because most of the not in the hospital, they are not in the setting. So if they come from home and there's no like well set up emergency, then this can end up to death, which
Right.
was probably preventable. So number three is increased intracranial pressure. So the increased ICP can be caused by brain metastasis, leading to headache, nausea, and vomiting, behavior changes, seizures, and focal neurological deficits. So if you have this, then I mean, the tumor can be resected. So we get patients from peripheral area to King Faisal where they can do MRI and whatever. So by that time, they said they are ready, and then the tumor will be resected and in emergency. So the increased ISP can occur through lymphomatous, meningitis, or CNS mass. This can be like presented as any other, I mean, space occupying lesion, but still we have to think about tumor. We have to think about any metastasis that is making the ICP to increase. So really important, really important. So I think the next slide will be a colleague talking about superior vena cava syndrome. Thank you.
Marcos.
Yeah, thank you very much. I'll be talking about the superior vena cava syndrome, which is a clinical manifestation of obstruction of blood flow through the superior vena cava. All right, and this leads to impaired venous drainage from the head, neck, upper extremities, and upper thorax. All right, and symptoms will include swelling in the face, neck, arms, and upper chest. All right, it can progress to difficulty with breathing, coughing, hoarseness, chest pain, can also lead to dizziness or fainting. All right, because of the impaired venous drainage from the arm, it can lead to bluish discoloration of the skin. All right, the prognosis actually depends on the underlying cause and the severity of the blockage. The good news is that with prompt and early treatment, most people with superior vena cava syndrome can recover fully. However, if this condition is left untreated, it can lead to serious complications such as heart failure or death. It's important for us to talk about the different etiology because management also will have to do with taking care of the primary cause. Malignant causes account for more than 85% of cases of superior vena cava syndrome. All right, these malignant causes range from lung cancer, lymphoma, or you can even have metastatic mediastinal tumors. The non-malignant causes account for the other 15%, which could result from thrombosis, which may form from the vessel itself, superior vena cava, is tributaries, or it may actually result from indwelling CVC or pacemaker leads, especially in the ICU when we have a lot of central venous catheterization. All right, other causes, non-malignant causes can be due to infections such as tuberculosis and syphilis. All this can cause inflammation and swelling that will obstruct the superior vena cava. All right, diagnosis, clinical features is important. All right, from what we talked about, the early features like swelling, facial swelling, periorbital and neck swelling, and all that. Then physical exams, all right, will give away some of these initial clinical features. Then imagings like chest X-ray, CT scan, and MRI. So the treatment, it's number one is want to address the underlying features. All right, this may involve, especially if it's related to cancer, you may want to do chemotherapy or radiotherapy, radiation therapy, and sometimes surgeries. All right. If it's due to infections, like your syphilis or tuberculosis, antibiotics will take care of the underlying cause. Endovascular stenting, all right, this is to open up the blocked part of the cerebral vena cava to allow blood to flow, all right, which is also very useful, especially in taking care of the symptoms. Anticoagulation therapy, especially if you have a thrombosis formed from whatever, maybe the indwelling central venous catheter. So anticoagulation therapy will help, all right? And this is important, especially patients with, respiratory problems, dyspnea, patients with difficulty with breathing. Oxygen therapy will help to improve the oxygen levels in the body. I think the next one, the next colleague will take care of the treatment-related complications. Thank you.
Excellent. Thank you so much, Dr. Toby. That was excellent.
All right, so for treatment for cancers, this can affect almost every organ system in the body. It is important to understand that each patient's type of cancer and the extent of its spread and the indicated treatments improve their prognosis, but also to avoid life-threatening complications of that treatment. So cardiovascularly speaking, chemotherapy, radiation, and targeted therapy can damage the heart and its blood vessels. Potential damage to the heart and blood vessels include high blood pressure, abnormal heart rhythms, so arrhythmias, and heart failure, according to the National Cancer Institute. Some drugs specifically, like the anthracyclines, are particularly linked to cardiotoxicity. Respiratory-wise, chemotherapy and radiation can cause damage to the lung tissue itself, leading to pneumonitis and fibrosis. Symptoms can include shortness of breath, coughing, wheezing, reduced lung capacity. Bleomycin is a chemotherapy drug commonly associated with lung damage. As far as the kidney and the bladder, chemotherapy and radiation to the pelvic and abdominal area can affect the kidneys and the bladder. This damage can decrease urine flow, swelling, fatigue, can cause headaches, as well as high blood pressure. Bladder problems can include irritation, pain and burning during urination, frequent urination, difficulty controlling your urine, so incontinence and blood in your urine. Cisplatin is a chemotherapy drug that has a lot of known nephrotoxicity. In the digestive system, chemotherapy commonly causes nausea, vomiting, mucositis, which is soreness in your mouth, in the GI lining, diarrhea, abdominal pain, and constipation. Radiation specifically to the abdomen and the pelvis can damage your intestines, your rectum, potentially leading to chronic radiation enteritis or proctitis. Long-term effects including scarring, strictures, bowel obstructions, ulcers, bleeding, fistula, and increased risk of colon cancer. As far as the nervous system, chemotherapy drugs like vinca alkaloids can cause peripheral neuropathy, which is numbness, tingling, and pain in your hands and your feet. It can cause motor and gait disorders, as well as autonomic neuropathy. Some targeted therapies can cause cognitive impairment, kind of termed as like chemo brain, or even intracranial hemorrhage. Radiation to the nervous system can cause fatigue, cognitive effects, cerebral vascular disease, neuroendocrine dysfunction, as well as secondary malignancies. Endocrine-wise, cancer treatment can damage your endocrine glands, like your thyroid, your ovaries, and testes. This can result in conditions like early menopause, infertility, hypo and hyperthyroidism. Reproductively speaking, both chemotherapy and radiation can affect ovaries, so leading to that early menopause, which I just discussed, irregular periods, and infertility. As far as the testes go, impotence and infertility can be seen. Ovarian
Danielle,
transposition. Yeah.
we are unfortunately we're running out of time. So I am just gonna say maybe we could summarize and say that there are lots of different chemotherapeutic agents, lots of different radiation treatments, lots of different types of cancers, and literally it can affect every system in the body. Is that
You're
fair
exactly
to
right.
say?
Yes.
Yeah.
Yes. Very fair.
Great. Is it okay if we move on to the next?
Yeah, sure.
Okay. Thank you so
out.
much for that thorough
Yeah.
thorough coverage of the different related complications. I know it's extensive.
Okay, so one of the newer treatment options that's out there now is cancer immunotherapy. So specifically CAR T therapy, checkpoint inhibitors, and things that really engage T cells and lead to inflammatory state of the body. So this commonly leads to something called cytokine release syndrome. And so I'm not going to read the whole abstract for you here. You guys can take a peek at it, or you can access the QR code. And this leads to a really great review article about cytokine release syndrome.
Yeah, CAR T therapy, this is a great diagram of what it is, but it's hiding a massive amount of genetic engineering, which is kind of a medical miracle in some respects. But what's done is basically the patient's blood is separated, and his own T cells, or which are a special type of white cells, are treated with a virus that replaces some of the DNA in those T cells with a code to make a certain type of receptor called the chimeric antigen receptor. Now, that's a fancy term for just a special receptor that allows it to identify cancer cells in a different way that T cells normally would, and also to activate the T cells, which is why it's called chimeric. So both things are happening to destroy those cancer cells. So it's amazing technology. They grow those whole population of those cells to get millions of them before they reinfuse back into the patient. And as you can imagine, there's chaos created when all these activated T cells latch onto cancer cells. So these patients can get very sick. We, of course, in the ICU see only the ones that are really getting into trouble, but they often can get very, very sick as a result of the therapy before they actually get better.
Okay, so in talking about that inflammatory cascade that oftentimes CAR T can lead to due to T cell activation, we'll talk a little bit about cytokine release syndrome, which is essentially an overreaction of the immune system, where immune cells like T cells are activated intentionally to treat the cancer, but they in turn release large amounts of cytokines, leading to what we sometimes refer to as a cytokine storm. It's typically characterized by rapid and excessive release of cytokines into the bloodstream, which leads to a range of symptoms that go from mild to potentially life-threatening. So a CRS, cytokine release syndrome, can occur after certain immunotherapies, but is particularly associated with CAR T cell therapy and can also happen with some infections. So we can move to the next slide. So how do we identify it and what do we do about it? So as so much of what we've talked about today, it's very much diagnosed clinically and considering your patient's underlying risk factors. So did they just get an immunotherapy or CAR T therapy and are now presenting with a clinical constellation concerning for cytokine release? So what are we going to look for in this circumstance? In the beginning, it's oftentimes starts with fever and nonspecific symptoms of inflammation. So someone who's getting periodic fevers or kind of fevers that are not responding to antibiotic therapy. CRS can also impact many different organ systems, and mild cases can look like a flu-like illness. More severe CRS can be life-threatening and include cardiovascular, pulmonary, and renal involvement. Neurotoxicity can also occur with the initial presentation, but it can also be more delayed. So things like fever, that's what you'll commonly see initially. Flu-like symptoms, fatigue, muscle aches, nausea or vomiting, sometimes diarrhea and headache. Respiratory issues like cough, tachypnea, and in severe cases, you can see acute respiratory distress syndrome or ARDS. For cardiovascular issues, oftentimes you'll see tachypnea, hypotension, and potential for cardiac dysfunction. And then neurologically, you can sometimes see confusion, seizures, delirium, and coma. And then other organ failure or organ involvement can include liver dysfunction and renal dysfunction as well.
Dr. Arkin, this sounds a lot like multi-system organ dysfunction to me.
Yes, ma'am, it is. And it's very nonspecific.
So like Nicole was saying, one of the important things is kind of determining the severity of the cytokine release syndrome, and that helps you determine how to treat it. So for just those low-grade symptoms, things like fever, malaise, a lot of times you can get away with just giving Tylenol and making sure they don't have an infection. What you have to be really careful with CRS is you want to make sure the CAR T cells are actually still able to do their job, because you want to remember you want them to treat the underlying malignancy. So if you give them steroids when they just have low-grade symptoms, you can actually inhibit the effectiveness of the cancer-treated therapy. As things get worse, though, then you get into life-threatening complications. So this is where we commonly start to see them in the ICU, or at least evaluate them for ICU admission. And these are grades 2, 3, and 4. So this is when you start getting hypotension, hypoxia, and this is where you start considering more aggressive therapies, things like IL-6 blockade with tocilizumab, or even just things like high-dose corticosteroids. We do sometimes the progression of CRS can be incredibly rapid, where within the course of hours, you can start just having low-grade symptoms to then a couple hours later needing mechanical ventilation and multiple pressors. And this is where, interdisciplinary collaboration with your oncologists and other people in your hospital is really important in administering some of these steroids and tocilizumab rapidly.
Yes, thank you so much, Dr. Amy. That's a really great point. And we do see them decompensate very, very quickly sometimes, and they're so sick, you wonder if they're going to make it. But the decision sometimes for the steroids and the tocilizumab are always multidisciplinary. So thank you so much for that. We are seeing a lot more CAR T therapy in our setting at Stanford, and so you're going to eventually see this in a lot of settings, assuming the resources expand and capacity builds for this type of therapy. So we are seeing a lot more CAR T therapy. We have covered a tremendous amount of information in this session. We tried to make it a case-based discussion, but that seemed very, very challenging to fit all of these complications and cancers into one patient, and it didn't seem to be very nice to do so. But just as a summary and review, we talked about the metabolic complications. Primarily, we discussed tumor lysis syndrome. Remember, that's when large numbers of tumor cells are destroyed and lice open, releasing the potassium and phosphate. And causing a decrease in calcium because of the calcium phosphate binding with renal dysfunction. And the management primarily rests on monitoring the labs, good hydration, allopurinol, and if available, rasburicase. Electrolyte abnormalities are common. Everyone should remember how to treat these. You can look at the earlier slide for that summary, but some of the common electrolyte derangements include hyper and hypocalcemia, hyperkalemia, SIADH, and hyperphosphatemia as well. Hematologic complications also very common. Today we discussed hyperviscosity syndrome, which may require plasmapheresis. We talked about leukocytosis and leukostasis, which requires chemoreductive chemotherapy first off, but may require hydroxyurea and leukapheresis if cytoreductive chemo is not able to be given right away. We talked a lot about, Dr. Jackson did an excellent job talking about neutropenic fevers and sepsis. Again, you want to isolate these neutropenic patients, but you want to keep them out of the hospital if possible. So you can use your CISNI and the other one was the MASC scoring system to determine if they're sick enough to be admitted to the hospital or if they're better off at home. These patients need not only isolation, but they need good sepsis care and early antibiotics and any supportive care that's indicated. Structural complications can include the primary tumor itself, but also can include metastatic disease. You always want to treat the underlying disease and the complications as indicated. SVC syndrome is a unique complication where the superior vena cava is obstructed by tumor infection or some other underlying disease state. You obviously want to treat the underlying disease state or cause of the SVC syndrome, but you may realize that you need to put in a stent or do some anticoagulation because of clot formation, because of that, the stasis of that blood. Patients often have respiratory symptoms with SVC syndrome, so oxygen therapy may also be indicated. Again, we treat cancers as best we can, and some of those treatments can cause complications or make the patient worse before they get better. We talked a little bit or a lot about direct toxicity of some of our chemotherapeutic agents, as well as the organ damage that can occur. And again, that's very specific to each case, so we need to review those underlying diseases and complications. More specifically, we talked about cytokine release syndrome. Although this can happen in other situations, it happens very commonly with CAR T therapy, a newer oncologic intervention. It requires supportive care, but if it's in grade 2, 3, or 4, those patients may need ICU level care, and grades 3 and 4 is where we start to consider steroids or tocilizumab therapy for that. So this is a summary. I want to remind everyone that we do have all of these slides and notes. They're available on sorry, I'm just switching.
I will again place the link in our chat group.
Thank you so much for that. Yeah, so we want to make sure that you recognize that all of this information is available on the Learning Resource Center. Here is the scan code. You can use the QR code to scan to get access to the Learning Resource Center. An additional thing to recognize is our next session is on September 17th, where we'll be discussing maternal hemorrhage and critical care related to that. Also, I know everyone is very, very interested in receiving certificates and CPD. If you registered for this session, you will receive a certificate of attendance. However, in order to receive CPD or CME, you must follow the instructions in the email that you received. The CME is offered by the Stanford CME office. So follow those instructions, fill out the evaluation, and you will automatically receive a CPD or CME certificate as well. I want to again thank my panelists. What a wonderful, wonderful team of speakers that we had today from Stanford and from Rwanda, giving us a well-rounded view of high resource setting and, well, there's very high resource settings in Rwanda as well, but greater familiarity with working in rural and district hospitals. So thank you so much, Dr. Fred, Dr. Amy, Dr. Nicole, Dr. Jackson, Dr. Toby, Dr. Gaston, and Danielle, my co-host for today. We're really, really grateful to all of you. And we will see you all again on September 17th. Thank you so much. Murakoze Jane.
Thank you. Thank you, Anna.
Yego.
Thank you, Anna. Thank you, everyone. Fred, Daniela, everyone. Thank you.
Thank you.
Thank you.
Thank you, Jackson.
There are some questions in the chat box that were answered. We can just take a look at it. All right.
Ooh, I
Maybe
love
for
that clap. That was great.
yeah. So
Yeah,
there's some questions that were
there's
I think
never
I
enough.
answered a bunch of them.
Yeah, there's never enough time, but I love all the questions in the chat and the Q&A. I got to learn how to do
Great.
that big clap. That's amazing. I need to work on my emoji skills.
Is it possible to gather some of these questions and file them?
Yeah, so what we do, Dr. Toby, is we collect all of the questions because when you register, you're also able to submit questions. And then through the webinars, we have lots of questions as well. So what we've done for the series, because we have 12 different webinars, we've already hosted one session that was called Frequently Asked Questions. We will do so again. Actually, session 12 is dedicated to just answering questions that we were unable to get to during the webinars themselves. Yeah, thanks for asking.
All right, great. Thank you, Anna.
There you go. I'm going to close Johnny. Okay, with that, we'll see you next month.
Bye, everyone.